Hi there, I'm a Psych NP and I have 25 test questions on intermittent explosive disorder. Ready? Let's learn Psych fast. Question 1. Which of the following best describes the characteristic feature of intermittent explosive disorder? A. Prolonged periods of stable mood. B. Chronic and persistent aggression towards others. C. Discrete episodes of losing control of aggressive impulses. Or is it D. Exaggerated response to minor stressors? The correct answer is C. Discrete episodes of losing control of aggressive impulses. Individuals with IED experience sudden, intense episodes of aggression or impulse behavior that are out of proportion to any provocation. These episodes are characterized by a loss of control over aggressive impulses, leading to severe assault or property destruction. Let's go over why the other options are incorrect. So option A, prolonged periods of stable mood. That's incorrect because individuals with IED experience discrete episodes of aggression rather than stable mood states. In fact, these episodes are marked by a sudden and dramatic change in mood and behavior. Option B, chronic and persistent aggression towards others. That's incorrect because although individuals with IED may exhibit aggressive behavior, the hallmark of the disorder is the presence of discrete episodic outbursts rather than chronic patterns of aggression. And then option D, exaggerated response to minor stressors. That's incorrect because while individuals with IED may react aggressively to relatively minor triggers, the key characteristic is the disproportionate nature of the aggression compared to the stressor. The term exaggerated implies heightened but still proportional response, whereas IED involves an extreme and disproportionate reaction. Question 2. What distinguishes intermittent explosive disorder from other psychiatric disorders? Is it A, chronic remorse and guilt following aggressive outbursts, B, aggressiveness that is proportional to the stressor, C, spontaneous remission of symptoms after each episode, or is it D, presence of generalized impulsivity between episodes? The correct answer is C, spontaneous remission of symptoms after each episode. So individuals with IED experience discrete episodes of aggressive outbursts that occur suddenly and out of proportion to any provocation. Importantly, after each episode, symptoms typically remit spontaneously and quickly without the need for external intervention. This pattern of symptom remission distinguishes IED from other psychiatric disorders where symptoms may persist over time or require ongoing treatment. And option A, chronic feelings of remorse and guilt following aggressive outbursts. That's incorrect because while individuals with IED may experience regret or guilt after their outbursts, chronic feelings of remorse and guilt may be present in other psychiatric conditions such as major depressive disorder, but it's not unique to IED. Then option B, persistent irritability and mood swings. That's incorrect because although individuals with IED may experience irritability and mood instability, these symptoms are not necessarily unique to the disorder. Many psychiatric conditions involve disturbances in mood regulation, and persistent irritability may be a feature of several disorders, including mood disorders and personality disorders. And then option D, the presence of generalized impulsivity between episodes, is incorrect as individuals with IED show signs of generalized impulsivity or aggressiveness only between episodes, not during the remission period. So while impulsivity is a common feature of IED during aggressive outbursts, it's not typically present during the periods of symptom remission. Question 3. How quickly do episodes of IED typically remit? A, days to weeks, B, hours to days, C, months to years, or D, minutes to hours? The correct answer is D, minutes to hours, because regardless of the duration of episodes of aggressive outbursts in IED, it does remit spontaneously and quickly. This means that individuals with IED may experience a sudden onset of aggressive behavior, which can escalate rapidly, but they resolve within a relatively short period of time, ranging from minutes to hours. Question 4. What is a key diagnostic criterion for IED? Is it A, chronic feelings of remorse and guilt, B, persistent irritability and mood swings, C, excessive alcohol consumption, or is it D, discrete episodes of aggression out of proportion to stressors? Option D is the correct answer because it aligns with one of the core diagnostic criteria for IED. Individuals with IED exhibit recurrent episodes of impulsive aggression or destructive behavior that are grossly out of proportion to any stressors or triggers that may have contributed to the outburst. This disproportionate response distinguishes IED from other psychiatric conditions where aggressive behavior may be more contextually appropriate. And option A, chronic feelings of remorse and guilt following aggressive outbursts, that's incorrect because individuals with IED may experience remorse or guilt after their aggressive outbursts. And this is not a diagnostic criterion for the disorder. Additionally, remorse and guilt may be present in other psychiatric conditions, so it's not unique to IED. And then option B, persistent irritability and mood swings. That's incorrect because while irritability and mood swings may be associated features of IED, they are not specific diagnostic criteria for the disorder. Again, many psychiatric conditions involve disturbances in mood regulation, and persistent irritability may be a feature of several disorders, including mood disorders and personality disorders. And then option C, excessive alcohol consumption. That's incorrect because while substance use, including alcohol use disorder, may co-occur with IED, excessive alcohol consumption is not a diagnostic criterion for IED itself. IED is characterized by impulsive aggression regardless of substance use. Question 5. When diagnosing intermittent explosive disorder, clinicians should exclude other potential explanations for the symptoms. What is the reason for this? A, the disorder is extremely rare. B, the disorder often occurs with other psychiatric conditions. C, the symptoms are not severe enough to warrant diagnosis. Or is it D, there are many other psychiatric disorders with overlapping symptoms? The answer is B. The disorder often co-occurs with other psychiatric conditions is the correct answer as it aligns with the key consideration in diagnosing IED. Clinicians should not diagnose IED if they can better explain the symptoms with another disorder. This implies that IED may share overlapping symptoms with other psychiatric conditions, making differential diagnosing challenging. Therefore, it is important for clinicians to consider and rule out alternative explanations for the observed symptoms before diagnosing IED. Option A is incorrect. The disorder is extremely rare. No, because while IED may not be as common as other psychiatric disorders, it's not considered extremely rare. Prevalence estimates suggest that IED is relatively common, particularly in clinical populations. Option C, the symptoms are not severe enough to warrant diagnosis, is incorrect because the severity of the symptoms is a reason for excluding other potential explanations. Actually, clinicians should consider alternative diagnoses if that can better explain the symptoms regardless of the severity being presented. And then option D is incorrect. While the statement itself is true, it does not fully capture the rationale for excluding other potential explanations. The primary concern is not simply the presence of overlapping symptoms, but rather the ability of other disorders to better account for the observed symptoms than IED. Question 6. Which of the following is a key feature of IED according to DSM-5 and ICD-10? A, episodes of aggression lasting more than 30 minutes. B, warning signs preceding aggressive outbursts. C, provocation that is proportionate to the aggressive response. Or is it D, age requirement below 6 years for diagnosis? The correct answer is option D, age requirement of above 6 years for diagnosis. This is the one that aligns best with the criteria outlined in both DSM-5 and ICD-10. The age requirement for the diagnosis above the age of 6 or of comparable developmental level. This requirement helps ensure that the diagnosis is applied to individuals who have reached a certain level of cognitive and emotional development where the behaviors can be reliably assessed and distinguished from normative behavior. Option A, episodes of aggression lasted more than 30 minutes, is incorrect because aggressive outbursts in IED typically last for less than 30 minutes. While the duration of episodes may vary, they are generally brief and rapid in onset. Option B, warning signs preceding aggressive outbursts, is also incorrect because while individuals may experience triggers or provocation, these outbursts typically occur rapidly and without warning. And then option C, provocation that is proportionate to the aggressive response, is incorrect because a key feature of IED is the disproportionate nature of the aggressive response to any provocation. Individuals with IED react with aggression that is grossly out of proportion to the triggered event, which distinguishes the disorder from normative behavior. Question 7. What is a distinguishing characteristic of aggressive outbursts in intermittent explosive disorder? Is it A, they occur with predictable triggers, B, they last for more than 30 minutes, C, they cause minimal distress or impairment, or D, they occur rapidly and typically without warning? All right, so this one you should definitely get because we've kind of gone over it. Did you get it? The answer is option D. They occur rapidly and typically without warning. This means that individuals with IED may suddenly and unexpectedly escalate into aggressive behavior, often catching themselves and others off guard. Option A is incorrect because while there may be some provocation or triggers preceding the outburst, the response is disproportionate to the triggering event, and the outbursts typically occur rapidly and without predictability. Option B is incorrect because aggressive outbursts in IED typically last for less than 30 minutes. While the duration of episodes may vary, they are generally brief and short-lived. And then, of course, option C, that's incorrect because one of the diagnostic criteria for IED is that the disorder causes significant distress or impairment in psychosocial functioning. The aggressive outbursts in IED are often associated with negative consequences for the individual and those around them, such as a job loss, marital difficulties, and trouble with the law. Question 8. How many episodes of loss of control associated with aggressive outbursts are typically required for diagnosis in IED? A, one discrete episode, B, two discrete episodes, C, several discrete episodes, or D, continuous episodes over a week. Option C, several discrete episodes, is the correct answer. The diagnosis of IED should be based on history taken that reveals several episodes of loss of control associated with aggressive outbursts. This implies that multiple episodes are typically required to establish the diagnosis rather than just one discrete episode. Question 9. What percentage of individuals with intermittent explosive disorder meet the criteria for another psychiatric disorder? Is it A, greater than 50%, B, around 60%, C, greater than 80%, or D, 100%? The answer is option C, more than 80%. There's a high prevalence of comorbidity with other psychiatric conditions among individuals diagnosed with IED. These include other disorders of impulse control and substance use, and mood, anxiety, personality like antisocial and borderline, post-traumatic stress, and eating disorders. Also, individuals with intermittent explosive disorder have been reported to be at increased risk of self-harm. Question 10. Which of the following types of disorders are commonly comorbid with IED disorder? Is it A, neurodevelopmental disorders, B, neurocognitive disorders, C, mood, anxiety, and personality disorders, or D, sleep-wake disorders? The answer is C, mood, anxiety, and personality disorders. IED frequently co-occurs with mood disorders such as depression or bipolar disorder, anxiety disorders, and personality disorders such as antisocial and borderline disorder. This indicates a broad range of psychiatric conditions commonly associated with IED. Option A, neurodevelopmental disorder, is incorrect. While neurodevelopmental disorders may occur alongside IED in some cases, it's not a primary comorbid condition. Then option D, neurocognitive disorder, also incorrect, because neurocognitive disorders primarily involve impairment in cognitive functioning rather than mood, anxiety, and personality disturbances. And then option D, sleep-wake disorder, not involved in IED. Question 11. Which of the following statements about the onset and course of IED is accurate? A, the disorder always has an insidious onset and a chronic course. B, episodes typically increase in severity with age. C, the disorder commonly starts in childhood and improves with age. Or D, onset can be sudden or insidious and the course can be episodic or chronic. The answer is D, as it accurately reflects the variability in the presentation of IED. The onset of IED can be sudden or insidious, meaning it may occur abruptly or develop gradually over time. Additionally, the course of the disorder can be episodic, characterized by intermittent outbursts, or chronic, indicating persistent or ongoing symptoms. Option A is incorrect. The disorder always has an insidious onset and a chronic course. No, because it presents a very rigid view of the onset and the course of IED, which does not align with its variability. Option B, episodes typically increase in severity with age. Nope, that's wrong, because in most cases, the severity of IED decreases with the onset of middle age rather than increase with age. And then option C, the disorder commonly starts in childhood and improves with age. Again, incorrect, because while IED may begin at any stage of life, it is commonly started in childhood. Additionally, the disorder decreases in severity with the start of middle age rather than improving with age in childhood. Question 12. What makes psychotherapy challenging for patients with IED? A, lack of interest in therapy. B, frequent mood swings. C, difficulty in recognizing and verbalizing thoughts and feelings. Or D, angry outbursts interfering with therapy sessions. The correct answer is D, angry outbursts interfering with therapy sessions. So psychotherapy can be particularly challenging for individuals with IED due to their frequent and intense angry outbursts. These outbursts can disrupt therapy sessions, making it difficult for therapists to establish rapport with their patients and maintain a therapeutic alliance. Angry outbursts may escalate quickly, hindering the patient's ability to engage in meaningful therapeutic work. Option A, lack of interest in therapy, and option B, frequent mood swings, are both incorrect because while some individuals with IED may initially struggle with the motivation for therapy or have mood instability, the primary challenges lies in managing the angry outbursts during the sessions. And then option C, difficulty in recognizing and verbalizing thoughts and feelings. That's incorrect because while it may be a challenge for some individuals with IED, the biggest challenge is the disruptive nature of angry outbursts during therapy sessions as the primary concern. Question 13. Which therapy modality may be particularly helpful for individuals with intermittent explosive disorder who are adolescents or young adults? Is it A, individual psychotherapy, B, group psychotherapy, C, cognitive behavioral therapy, or D, dialectical behavioral therapy? The correct option is B, group therapy. So group psychotherapy can be especially helpful for adolescents or young adults with IED because it provides a supportive environment where individuals can interact with their peers facing similar challenges. Group members may offer validation, empathy, and encouragement to each other, fostering a sense of camaraderie and reducing feelings of isolation. Additionally, group therapy allows participants to learn from one another's experiences and coping strategies, providing valuable insights and perspectives. Question 14. Which class of medications has been reported as useful in generally lessening aggressive behavior? Is it A, antipsychotics, B, benzodiazepines, C, anticonvulsants, or D, antidepressants? The correct answer is option C, anticonvulsants. So anticonvulsants such as carbamazepine, valproate, Phenytoin, and sometimes topiramate have been reported as useful in generally lessening aggressive behaviors in individuals with IED. These medications are commonly used to treat seizure disorders, but have also been shown to be good at reducing impulsive and aggressive behaviors in various psychiatric conditions, including IED. They may help stabilize mood and reduce the frequency of severity of the impulsive outbursts. Question 15. How do anti-adrenergic agents influence aggression? A, they increase aggression. B, they have no effect on aggression. C, they decrease aggression. Or D, they exacerbate impulse aggression. The correct answer is C, they decrease aggression. High CSF testosterone concentrations are associated with increased aggressiveness and interpersonal violence in men. Anti-adrenergic agents, which counteract the effects of androgens such as testosterone, have been shown to decrease aggression. By inhibiting the action of testosterone or reducing levels of anti-adrenergic agents can mitigate aggressive behaviors in individuals with IED or other conditions characterized by impulse aggression. Option A, they increase aggression, is incorrect because anti-adrenergic agents act to reduce the effects of testosterone, which in turn decreases aggression. And option B, they have no effect on aggression, is incorrect because anti-adrenergic agents have been shown to decrease aggressive nature, indicating effects on aggressive behavior. And then option D, they exacerbate impulse aggression, is definitely incorrect because the opposite occurs. Anti-adrenergic agents decrease aggression rather than exacerbating it. Question 16. Why might clinicians question the diagnosis when considering the use of antipsychotics or tricyclic drugs in treating IED? A, due to their potential side effects. B, because these medications worsen aggression. C, to determine if the patient has schizophrenia or a mood disorder. Or D, to assess the patient's response to psychotherapy. The correct answer is C, to determine if the patient has schizophrenia or a mood disorder. Antipsychotic and tricyclic drugs have been effective in some cases of IED. However, their use requires careful considerations. Clinicians must question the diagnosis when considering these medications because their efficacy raises concerns about whether the patient's symptoms may be better explained by a primary psychotic disorder such as schizophrenia or a mood disorder such as bipolar disorder. Misdiagnosis can lead to inappropriate treatment and potentially worsen the patient's condition. Question 17. What medication has been effective in reducing aggression and impulsivity in some cases of intermittent explosive disorder? A, propranolol. B, lithium. C, carbamazepine. Or D, phenobarbital. The correct answer is B, lithium. Lithium has been reported as useful in generally lessening aggressive behavior in individuals with IED. It is commonly used as a mood stabilizer in bipolar disorder and has been shown efficacious in reducing impulsivity and aggression across various psychiatric conditions, including IED. By stabilizing mood and reducing impulsivity, lithium may help mitigate the frequency and severity of impulsive outbursts in individuals with IED. Option A, propranolol, is incorrect because, it's a beta-adrenergic receptor antagonist that may be effective in some cases of IED, but it's not generally used to lessen the aggressive behavior in IED. And then option C, carbamazepine, that's incorrect. That along with valproate and phenytoin, they all belong in class of anticonvulsants that have been reported as useful in generally lessening aggressive behavior in individuals with IED. However, the question specifically asks for the medication that has been effective in reducing aggression and impulsivity, which is lithium. Question 18. What is the effectiveness of operative treatment for intractable violence and aggression in patients with intermittent explosive disorder? Is it A, high success rate, B, moderate success rate, C, low success rate, or D, no evidence indicates effectiveness? The correct answer is D, no evidence indicates such treatment is effective. So some neurosurgeons have performed operative treatment in intractable violence and aggression in patients with IED. However, there's no evidence indicating the effectiveness of such treatments. This implies that while these procedures may have been attempted, their efficacy has not been established through scientific research or clinical trials. Question 19. What therapy modality aims to have the patient recognize and verbalize the thoughts or feelings preceding explosive outbursts? Is it A, dialectical behavioral therapy, B, cognitive behavioral therapy, C, family therapy, or D, contingency management? The correct answer is B, CBT. So cognitive behavioral therapy, CBT, aims to help individuals with IED to recognize and modify maladaptive thought patterns and behaviors associated with their explosive outbursts. By teaching patients to identify their thoughts or feelings that precede their anger and aggression, CBT facilitates the development of coping strategies and problem-solving skills to manage these emotions more effectively. Verbalizing these thoughts and feelings in therapy sessions allows patients to gain insight into their triggers and learn alternative ways of responding to provocation. Question 20. What role does physical abuse in childhood play in the development of IED? A, it is not associated with IED. B, it is independently associated with intermittent explosive disorder. C, it is only associated with other psychopathologies. Or D, it has no impact on impulsivity and aggression. The correct answer is B, it is independently associated with IED. So physical abuse during childhood has been identified as a significant factor contributing to the development of intermittent explosive disorder. Research suggests that individuals who experience physical abuse are more likely to exhibit impulsive and aggressive behaviors characteristics of IED. Importantly, these associations hold true even when considering other psychopathologies, suggesting that physical abuse independently contributes to the risk of developing intermittent explosive disorder. Option A, it is not associated with IED, is incorrect because numerous studies have demonstrated a clear association between physical abuse in childhood and the subsequent development of intermittent explosive disorder. And then option C, it is only associated with other psychopathologies, is incorrect because while physical abuse may contribute to the development of various psychiatric disorders, it is specifically identified as a risk factor for IED. And then option D, it has no impact on impulsivity and aggression, is incorrect because evidence suggests that physical abuse during childhood can indeed lead to increased impulsivity and aggression, both of which are characteristic features of IED. Question 21. Which brain region dysfunction is associated with impulse aggression? Is it A, occipital cortex, B, prefrontal cortex, C, cerebellum, or D, the brainstem? The correct answer is B, prefrontal cortex. And why is that? Because it plays a critical role in regulating impulse behavior and aggression. Dysfunction in the brain in this brain region has been consistently implicated in individuals with impulsive aggression, including those with IED. Research has shown that deficits in the prefrontal cortical functioning area can lead to difficulties inhibiting inappropriate responses and regulating emotions, contributing to impulse and aggressive behaviors. Option A, occipital cortex, that's incorrect because the occipital cortex primarily processes visual information. And option C, cerebellum, is incorrect because that's more to do with motor coordination and balance. And then option D, the brainstem, incorrect because that regulates basic physiological functions such as heart rate and respiration. Question 22. How do serotonergic neurons influence behavioral inhibition? Is it A, by increase in punishment sensitivity, B, by decrease in punishment sensitivity, C, by promoting impulse behavior, or D, by enhancing aggression? The correct answer is B, by decreasing punishment sensitivity. So serotonergic neurons play a crucial role in modulating various aspects of behavior, including behavioral inhibition. Decreased serotonergic transmission, which can result from inhibiting serotonin synthesis or antagonizing its effects, reduces the impact of punishment as a deterrent to behavior. In other words, when serotonin levels are low, individuals may become less sensitive to negative consequences, making them more likely to engage in impulse or aggressive behaviors despite potential punishment. Option B, by decreasing punishment sensitivity, is incorrect because decreased serotonergic transmission leads to reduced sensitivity to punishment rather than an increase. And then option C, that's incorrect. By promoting impulse behavior, no. That's incorrect because while decreased serotonergic transmission can indeed contribute to impulsivity, the specific mechanism that involves a reduction in punishment sensitivity rather than a direct promotion of impulse behavior. And then option D is incorrect, by enhancing aggression. That's incorrect because while serotonin dysregulation has been associated with increased aggression, the impact of serotonergic neurons on punishment sensitivity rather than directly enhancing aggression. Question 23. What correlation has been found between CSF 5-hydroxyindolosidic acid, also called 5-HIAA, levels and impulse aggression? Is it A, high levels correlate with the impulse aggression, B, low levels correlate with impulse aggression, or C, there's no correlation, or is it D, moderate levels correlate with impulse aggression? The correct answer is B, low levels correlate with impulse aggression. So research has indicated a potential inverse correlation between cerebrospinal fluid, CFS, and 5-HIAA and impulse aggression. So 5-HIAA is a primary metabolite of serotonin that is broken down the liver and then excreted by the renal system. This neurotransmitter is implicated in mood regulation and impulse control. Studies have suggested that lower levels of 5-HIAA may be associated with increased impulsivity and aggression, although the relationship is complex and influenced by various factors such as genetics, environment, and psychiatric disorders. Several studies, including those on individuals with antisocial personality disorder and violent offenders, have reported lower levels of CSF 5-HIAA in individuals exhibiting impulse aggression behaviors compared to controls. However, it is important to note that the correlation does not imply causation. There is no one-to-one relationship between serotonin and aggression, but rather a complex interplay among various factors like biological, psychological, and social. Additionally, other neurotransmitters and neurobiological factors are likely to play a role in the manifestation of impulse aggression. Question 24. What is the familial relationship between individuals with IED and their first-degree biological relatives? Is it A, no association, B, they are less likely to have IED, C, they are more likely to have IED, or D, they are equally likely to have IED? The correct answer is C, they are more likely to have IED. There is evidence indicating that a higher prevalence of intermittent explosive disorder among first-degree biological relatives of individuals with the disorder compared to the general population. This implies that familial aggregation of IED, suggesting that genetic factors may contribute to the risk of developing the disorder. There are other familial and social factors that may influence this association. It highlights the increased likelihood of IED in biological relatives of affected individuals. Last question, question 25. What may increase the likelihood of impulsive, aggressive behavior after exposure to childhood maltreatment? Is it A, specific dopamine gene polymorphism, B, specific serotonin gene polymorphism, C, specific neuroepinephrine gene polymorphism, or D, specific opioid gene polymorphism? The correct answer is B. So individuals with specific serotonin gene polymorphism may be more prone to impulse aggression behavior after exposure to childhood maltreatment. This indicates a potential gene-environment interaction where genetic predisposition interacts with environmental factors, such as a childhood maltreatment, to increase the risk of impulsive aggression and consequently IED. All right. Hope this was helpful for you. Go ahead and click on this next video to learn about other childhood disorders. Thank you.